Hi guys, welcome back. The topics that we're gonna study here is diabetic ketoacidosis and non-ketotic hyperosmolar coma. DKA is more common in type 1 diabetes, whereas non-ketotic hyperosmolar coma with type 2. But before we look into how the patient will present and what will be the treatment protocol for the patient, we will have a look at some background information from biochemistry perspective for the two disorders. With diabetic ketoacidosis, the primary problem would be an absolute insulin deficiency, as a result of which the sugar will not be able to go inside the cells. Sugar is present everywhere, but the cells are not going to be getting that nutrition. So this patient is rather having a intracellular starvation. Just to describe this condition, I can say that you can imagine a person sitting in a boat in the middle of a sea. There's water everywhere, but the person cannot drink sea water. Similarly, in this particular patient, there's sugar everywhere, but the sugar cannot be utilized because the main key which will facilitate the entry of sugar into the tissues like adipose tissue or muscles is lacking. Therefore, the cells will be utilizing an alternative source of energy. The alternative source of energy will be fats. Because of the subcutaneous fat oxidation that will be occurring in this patient, there will be production of free fatty acids. These free fatty acids will then contribute to production of ketones, and ketones are acidic in nature. So this is going to contribute to decrease in the pH of the blood. Let me say the average pH of blood is 7.4. In this patient, it will decrease to 7.2, 7.1 or even lesser than that. So the family member of this child of type 1 diabetes mellitus who has landed up into diabetic ketoacidosis and is currently unconscious, his father or mother is asking you, doctor, the pH has decreased from 7.4, because let me say they are science graduates, they're not doctors, but parents are science graduates. So they have a bit of idea from chemistry perspective about pH. So they are saying, sir, pH you are telling me is decreasing from 7.4 to 7.0. It's a decrease of only 0.4 points. So what's the big deal about it? Well, the big deal is that because there is generation of protons, it's going to contribute to development or damage to the blood-brain barrier. And the statement that I say next has been asked in the exam in the previous years in pediatrics/medicine overlap. The question said, what contributes to death in a patient with diabetic ketoacidosis? Then it is cerebral edema due to the damage by the blood-brain barrier, primarily because of the protons which are being produced in excess thanks to the ketones. There are three of them: beta hydroxybutyrate, acetoacetate and acetone. In fact, if I mention the mortality values here, you will very well see why am I worried for this patient. The mortality rate can go up to as much as 20% if the age of the patient is more than 40 years. And that's why I'm saying that this disease can be seen in type 2 diabetes, but is more common in type 1 diabetes mellitus. But the mortality rate is relatively lesser if the age group of the patient is also lesser. So I can therefore say that though children have a better prognosis, but still, because these figures are pretty substantial, encephalopathy will ensue. So the next query of the parent and obviously the examiner will be that why is there a development of a absolute insulin deficiency in this patient? I mean, this type 1 diabetes mellitus patient could be receiving insulin injections. Then what really suddenly went wrong? Well, one of the important reasons can be simply that the insulin pump which is being used in this case can malfunction. Or let me say, if we are not talking about foreign country where insulin pump will be easily available, from Indian perspective, let me say there's a marriage in the family and the parents are busy and they forgot to give insulin injections to the child, and the child has not been trained properly to give insulin injections to himself or herself. Or let me say another way, the child had a bout of vomiting, maybe because the child had food poisoning, and because the child was vomiting continuously, the mother thought that because child is not eating anything, so she should not give insulin. So in majority of cases, there is a substantial insulin deficiency. I mean, I agree that in type 1 diabetes mellitus, there is anyway insulin deficiency. Here I use the word absolute insulin deficiency. So just to highlight what I said, I want to say that the triggers that are responsible for diabetic ketoacidosis can be remembered as 3 I's here. I mean, the 3 I's here would basically imply that either there could be a substantial insulinopenia, which I'm highlighting anyway, but another reason could be that this person could be having a sudden jump in the energy requirements of the body. The sudden jump in energy requirement could be due to an infection, like a child who's type 1 diabetic has developed a pneumonia. As a result of it, the energy requirement in the body will increase, but because he is sick because of pneumonia, his oral intake will decrease. If oral intake will decrease, the mother will not give insulin injections, as a result of which the ketone production will definitely increase in this patient. So I have just mentioned the 3 I's here. The reason for insulin deficiencies are manifold. So I just have to jot them down for your convenience, for your notes also. Though I have verbally said them. One is simply an insulin pump malfunction. Second could be a poor compliance or a poor understanding of the parents, especially with respect to minor illnesses. You need to tell the parents that, okay, if your child has not eaten a meal, he's eaten half of the meal, you need to give half of the insulin dosage. But do not stop insulin administration continuously for days altogether just because the child is not well, because we can treat these problems. I mean, pneumonia can definitely be treated, or if it's an adult patient who's had any kind of infarction, let me say myocardial infarction or stroke, these are triggers which will increase the energy requirement of the body, and anyway the insulin is less in the body of these patients, and because they are sick they might actually be non-compliant with administration of insulin injections. The infections which are common in older age group in diabetic patients is UTI. When it comes to especially pediatric patients, I can say pneumonia can definitely be developing. It could be COVID-19 pneumonia, it could be a routine pneumococcal pneumonia, and then I can also say that in younger people there can be drug abuse also, because cocaine again contributes to triggering or diabetic ketoacidosis, or the patient might have to undergo any kind of elective surgery, or even I would say emergency surgery due to any kind of a minor or a major accident. So all these factors that I've written before you, especially with respect to adult patients having MI, stroke or development of any infection, what's going to happen in these patients will be the values of sugar will begin to rise. Why? Because the body will now be utilizing the counter-regulatory hormones. The body will try to increase the value of glucagon and catecholamine and cortisol. You see, every time there is stress on the body, cortisol is the stress hormone, so it will increase and it will try to increase the blood sugar. So there are two problems that are occurring in this person. One, this person is very sick, the body requirement is going up, the body is trying to increase the value of sugar, and all these counter-regulatory hormones that I mentioned like cortisol or glucagon, growth hormone, they all decrease ketolysis. You can very well understand ketones are being produced in these patients because of insulin deficiency, because the person is sick, so insulin injections were not given. It could be simply lack of understanding on the part of the parent, or maybe even from the medical perspective, when the child was admitted in the hospital, the dosage of insulin given was relatively lesser as compared to what was the current blood sugar values. And more importantly, because ketolysis is occurring in this patient and is lesser, therefore ketones are being produced more, but they're not getting destroyed. On the basis of all these facts, I think from the background biochemistry domain, you will be in a better position to now understand the clinical manifestations of these patients. And initially, you might actually think that you're reading about a patient who's having pancreatitis, because nausea, vomiting and abdominal pain are one of the very highlighting, striking features of the disease, and that will further decrease oral intake of the patient. And if oral intake is decreased, mother has stopped insulin also. See, the usual query here is that why is there so much of nausea and vomiting? So I want to tell you that ketonemia can contribute to irritation of the chemoreceptor trigger zone. Therefore, there would be protracted vomiting in this case, and simultaneously the abdominal pain will mainly be concentrated in the epigastrium. So I said even a thought process of yours could be because in any patient with acute abdomen, you might get a baseline amylase levels done, and serum amylase levels are grossly elevated in these patients. The background information, if provided in the MCQ, will always be great. I mean, if he begins by saying it's a type 1 diabetes mellitus patient who has recently stopped insulin due to various reasons. It could be stoppage of insulin due to infection. It could be a marriage ceremony in the family. It could be simply that the child has stopped eating because of food poisoning episode that occurred recently. But if he gives you this information, then I think from the exam perspective, the question would be very, very easy for you, because that's the standard info that you know from your medical college days. I mean, type 1 diabetes mellitus patients are predisposed in insulin deficiency of the absolute variety to develop this ketoacidosis. Now, my next problem is that because blood sugar is rising, therefore the plasma osmolarity will also be rising. You very well know plasma osmolarity would be a range in the range of about 275 to 295 milliosmoles. Some books say about 280 to 290. My point is, in this case, the sugar values are rising, so the osmolarity of the plasma could go up to about 320 milliosmoles. See, the second topic that we will study after this is hyperosmolar coma. There the values can even be more than this. But whenever there is going to be an increase in the plasma osmolality, it will contribute to fluid shifts across the brain. And because of these fluid shifts that will occur across the brain, therefore this child will become lethargic. There can be stupor, there can be presence of coma. So earlier I was just highlighting the word cerebral edema, but at the moment I am saying that apart from acidosis that damages the blood-brain barrier, the gross elevations of sugar in the body of this patient, the hyperosmolarity is also contributing to fluid shifts and development of CNS manifestations. The high sugar will also contribute to development of osmotic diuresis. So therefore, there would be a polyuria, and most of the time you will notice that if a unconscious, unresponsive type 1 diabetes mellitus patient is admitted to my hospital because he is unconscious, unresponsive, I don't want the patient to soil the hospital bed, so I might put up a condom catheter or a Foley's catheter, and the bag will become full. I mean, there would be extensive amount of diuresis that occurs in these patients, which is osmotic diuresis. Polyuria definition you very well know, more than 3 liters on a daily basis. And if the patient at the moment is not lost his ability to respond to situations, early part of the disease, the family member might say that this child was asking for water again and again and subsequently lost consciousness, and anyway you have noticed that the urobag is full, there is a substantial amount of diuresis occurring in the child. As a result of this, because CNS manifestations are pronounced, the message is encephalopathy might be written in the question. But there are obviously no meningeal signs in the patient that you have definitely taken care of. I mean, any unconscious, unresponsive child, you're anyway gonna go in and check for neck signs in the patient. And then subsequently, what I am also noticing when I'm bringing my face close to the face of this child is that there is a fruity odor in the breath, and that's because of the acetone which is being excreted in the breath of this patient. When I'm gonna check out the vitals, the heart rate will be increased. Blood pressure can be normal to slightly elevated. If there is substantial amount of dehydration, blood pressure can be lower also. So I have not written any blood pressure value here because in the exam we can mention it to be on the lower side and even on the higher side due to sympathomimetic stimulation occurring here and counter-regulatory hormones being released. Respiratory rate will anyway be increased, and you will be having that acidotic hyperventilation, which is referred to as Kussmaul breathing. The message is that why is this Kussmaul breathing occurring in this patient? Then I want to say that this is a compensatory mechanism. When I say compensatory mechanism, how is it going to be occurring? So I'm just going to describe this very basic reaction to you, that carbon dioxide combines with water to form carbonic acid. I mean, you know this reaction very well. All I'm saying is that there's going to be generation of protons and bicarbonate, and protons are in excess. Now, because the protons are in excess, so what's going to happen? These protons are going to cause consumption of the bicarbonate which is present in the blood, and therefore in all MCQs of diabetic ketoacidosis, you will notice that the value of bicarbonate will always be lesser than normal. Normal is in the range of about 22 to 26, some books say 22 to 28, but the bottom line here is that the values would be less than 15 milliequivalents. Now, because of the fact that there is going to be more of these protons, therefore I can say this reaction will proceed in this direction. I'm saying it from the chemistry perspective, because there is excess of protons, they have to be neutralized. So how will the body neutralize it? There is going to be more production of H2CO3, more production of carbon dioxide here, and this carbon dioxide will stimulate the respiratory center, and therefore this person was having a very deep and fast breathing, and therefore I said Kussmaul breathing is an acidotic hyperventilation, because if you look at this reaction here, if this carbon dioxide keeps on going out of the body, if the person is breathing fast, if carbon dioxide is going out of the body due to hyperventilation, it will basically consume these protons, because if you remove carbon dioxide from this reaction, then more protons will have to bind to more of bicarbonate, and therefore the consumption of protons will keep on occurring. So the body is trying to rather utilize these protons which are in excess and are contributing to damage to the blood-brain barrier of this patient. Let us now look at the workup of these patients, and the first test that I'm going to do will be a urine examination. I will be having dipsticks available in my casualty, so I'm going to order for the urine sample of this patient being tested with keto sticks. You see, the disadvantage of keto sticks is that it is not able to detect one of the common ketone bodies which would be grossly elevated in the body of these patients. So there is a possibility that the urine dipstick may be false negative as well. I repeat the fact once again. Beta hydroxybutyrate is one of the predominant ketone bodies which is produced in excess in the body of these patients. But because the keto sticks may not be able to detect it, so I will be more comfortable to actually check out the plasma beta hydroxybutyrate values. And if the question simply says what is the best test to confirm the diagnosis of diabetic ketoacidosis, then plasma beta hydroxybutyrate values is the short way that, you're gonna be sure that, okay, I'm gonna be dealing with a case of diabetic ketoacidosis. When I will be checking the random blood sugar of this patient, it will definitely be spiking, but will usually be less than 600 mg/%. Why I'm saying that is because the subsequent topic that we'll talk about, hyperosmolar coma, the word hyperosmolar coma itself tells you that the blood sugar is grossly elevated. So most of the time in hyperosmolar coma, the sugar values can be in the range of 600 to 1200 mg/%, whereas they're usually less than 600. I've given you a value of approximately what we get usually in most cases, about 350 mg/%. And now comes a very important aspect with respect to insulin. So I want you to listen to my next information very carefully. First and the foremost is the basic rule that I've taught you even in the chapter of electrolytes, and that's one of the very important discussion in the app that I would definitely like you to listen to. pH is always inversely related to the potassium values. So whenever there's going to be acidosis is definitely going to contribute to a compartmental shift. And this compartmental shift will contribute to rise in the serum values of potassium. Now, I repeat my statement. I said there is a compartmental shift. So there is a possibility that when the person is admitted into your hospital right now in an unconscious state, the potassium in the blood is elevated. But at the same time, because this person was having vomiting, therefore, the total body potassium might even be lesser. Very two paradoxical statements. So let's have a look at them once again. The point is, because of the GI losses from the body of this person, total body potassium may be less, but in the blood, this potassium might be elevated. Obviously, if it is normal, it's a good news per se, because potassium can obviously contribute to excess or more. Both of potassium, excess and more, are dangerous. They can contribute to tachyarrhythmias. You very well know hypokalemia causes Torsades de Pointes. If it is a hyperkalemia, there can be a ventricular fibrillation or even a diastolic arrest of the heart. So it's a very dicey situation to have electrolyte imbalances. But because electrolyte imbalances are present in these patients, therefore you should be knowing that on admission in majority of cases, that's important, on admission in majority of cases, values can either be normal or can be elevated in the blood, but overall there is a depletion in whole of the body because of the GI losses. Now, before I go to the next electrolyte, they have asked which ketone body levels can be normal in diabetic ketoacidosis. Very surprising question. I said there are three ketone bodies, beta hydroxybutyrate. I just used a short form here. Another one that is present is acetoacetate, which is converted into acetone, and then acetone can be excreted in the breath of the patient. Now, my point is that acetoacetate, look at the arrow in green that I've drawn. If acetoacetate will be converted into acetone, this acetone will anyway be, excreted in the breath of the patient. This acetone is getting lost from the body. But because acetoacetate is getting converted into acetone, therefore the values of this might be even normal in spite of the fact that it is being produced, because it is getting converted into another ketone body, values can be normal also. Why they ask this question is just to see this component, that are you aware of the fact that all ketone bodies will anyway be grossly elevated, but acetone values can be normal in these patients, which again explains the fact that why I did mention that the investigational choice for this condition is plasma beta hydroxybutyrate, because if I would have tested for acetoacetate, I might have gone, or rather I would have got a false negative report as well. Let's now look at another electrolyte here, another important part of the discussion that's always asked with respect to the sodium values. Sodium, potassium, they always love to ask you, and especially in ketoacidosis, there is all the more reason. So let's look at what really happens in these patients. I agree, obviously, in mild cases, the values can be normal. But then there's a problem that is occurring in these patients with respect to elevated blood sugar, and sugar will cause solvent drag. It will remove water from the cells. When you remove water from the cells, this solvent drag can contribute to development of hyponatremia. Why did I say that? I said the solvent drag, that's a more of a chemistry concept, will draw in water into the blood. If you draw water into the blood, it will cause a dilutional component coming in, and therefore to make the MCQ sound a little sophisticated, he will say the word hypertonic. Why hypertonic? Because the plasma osmolarity is more. That's why the sugar is being able to, when I say hypertonicity, that means osmolality is more, sugar is more. It's drawing in water. So it's going to contribute to a dilutional component, and therefore there will be a hypertonic hyponatremia which is occurring in this patient. And why this is important from the exam perspective is because lots of guys, when they read it casually, they might mistake it or they might confuse it with an alternative term that I've discussed in the electrolytes discussion, that is hypervolemic hyponatremia. So at this particular junction, I will just mention few words regarding hypervolemic hyponatremia also, assuming the fact that you have not read the electrolyte discussion and you straight away come to the electrolyte part of diabetic ketoacidosis. In hypervolemic hyponatremia, what happens is that total body water is more and total body salt is more. But look at what I'm saying. The amount of water in the body is more than the amount of salt. I did not say more sugar in the body. I said more water in the body. Though no sugar component coming up here is more as compared to the amount of salt in the body. Conditions where you get hypervolemic hyponatremia is conditions contributing to ascites. It could be cirrhosis, nephrotic syndrome, protein losing enteropathy. His decision, whatever he wants to ask. Congestive heart failure can again occur due to coronary artery disease. It could be cardiomyopathy in a patient. It could be COVID-19 contributing to myocarditis. But the bottom line is, if he gives you this situation which is in the green box, it's gonna be a hypervolemic hyponatremia. The hormone which is playing a role in this case is aldosterone, which is drawing in water as well as salt, and therefore we call it hypervolemic. But at the same time, when I say hypertonic, the word is hypertonic, that means osmolality of the plasma is more, and therefore the sodium values are decreased in the patient. And I have just put N here to say that don't be surprised if they give you a question where values are normal. Initial development of disease, there will be no electrolyte imbalance. But my job is to tell you, when you have a really sick patient with pH of 6.8, yes, outrageous, no, pH of 6.8, 6.9, outrageously low values, then you could be having these aspects which are present. The learning part is sodium would be less and potassium values would be elevated. I will be next mentioning some mathematical values before you for the solvent drag aspect that I explained on the previous slide. You see, if the blood sugar of a patient rises by 100 milligram percent, let us assume at the moment blood sugar of the patient is 300 milligram percent, goes up to 400 milligram percent, then it will contribute to fall in the sodium values, as I explained to you, dilutional component coming up here. So the sodium values will begin to fall by approximately 1.6 milliequivalent. Now, when I say this fact, the query of a lot of people is that, sir, in a different section of the app, you have set different values, that when the sugar will rise by 100 points, the sodium values will fall by 3 milliequivalents. Gross difference, no? Earlier I was saying 1.6 milliequivalent, now I'm saying 3 milliequivalent. So what's really going on, sir? Or like chakkar kya hai? So the basic point is, guys, if sugar is grossly elevated, if it's like 400, 500, 600, higher is the sugar value, solvent drag is also more. So if suppose sugar is 800 milligram percent and it goes up to 900 milligram percent, the solvent drag will be more, than sodium will decrease by 3 milliequivalents. But if the sugar values are usually in the range of less than 400, then from 300 to 400, the fall will be 1.6 milliequivalent. I will just jot down the values here. You don't need to take down notes on it. I said if the blood sugar of the value is total absolute value is less than 400 milligram percent, then for every 100 point rise of sugar, the sodium falls by 1.6. But if the sugar values are, it's actually a range here again, 400 to 500, 400 to 600. But the bottom line is, higher is the sugar values, Therefore, the solvent drag will also be more and the fall will also be different. So you need to remember the both aspects here. I mean, 1.6 is the first thing that I want you to remember, inverse relation of sodium as well as that of sugar. But at the same time, even the magnitude of fall from 1.6 to 3 millicoulombs, the range that I explained has to be understood. Let's look at the next electrolyte which will be affected here, and that's going to be phosphate. There's a possibility that in the question he might mention phosphate values to be elevated. Why elevated? Because there might be a dehydration component occurring in this patient. See, in phosphate also the problem is same as that of potassium, that there might be a total body phosphate depletion. That's because of the losses that is occurring. So just like in potassium, I was saying that potassium in the body is lesser, though in the blood might be elevated. Same concept coming up here also. Total body phosphate may be less, but in the blood it might be elevated. And then we will also check out the KFT of the patient. You will notice that blood urea nitrogen creatinine will be increased. The reason for these findings will be dehydration component. There is a polyuria, but it is not being compensated with polydipsia. The person is sick, he may not be able to take orally. So because the intake is lesser as compared to the output, the dehydration component contributes to a deranged kidney function test in these patients. Now I will be doing a arterial blood gas analysis, ABG. But let me say that the relatives did not allow a arterial puncture permission. So I thought, okay, let me do a VBG in the patient. Yes, venous blood gas analysis can also be done, because here I do want to check out the PO2 values. This is not a COVID-19 patient that I am very particular about what is the value of PO2 of this patient. I am more concerned about the pH and the bicarbonate, and in arterial blood and in venous blood, as far as pH and bicarbonate are concerned, there are only few minor point differences. So VBG can be used. Now when I will scan the report, I will notice the following inputs. pH will be less, PCO2 will be less, bicarbonate will also be less. All the three arrows will be going in same direction. Whenever there's a metabolic problem in the body, you will always notice that pH, PCO2, bicarbonate always will be going in the same direction, because pH is less. I'm writing the word metabolic acidosis, and now I'm adding a technical word here, partially compensated. Why am I saying partially compensated? Well, you will be able to understand this better if you listen to the ABG discussion. But at this moment, my only statement is, and that will help you understand this, is that whenever protons are more, to neutralize the protons, what is required? Bicarbonate. And how will the body try to, note, and now I will add a word here, that is partially compensated metabolic acidosis. Now, if you want a better understanding of why am I saying partially compensated, you need to listen to the ABG lecture. But in case you have not listened to it, I'll still try to solve it here for you. The bottom line is, because in these patients bicarbonate is lesser. Why? Because it is getting consumed. If bicarbonate is getting consumed and it is becoming lesser, the body will try to hyperventilate to remove the carbon dioxide from the body. And look at the arrow of carbon dioxide, it is lesser. That means hyperventilation is occurring, no? So the lungs are trying to compensate here. The lungs are trying to help the body get rid of this extra protons. The chemistry equation that I've already shown before you, I'll just show this equation once again. I said in these patients bicarbonate is consumed, but since the protons are contributing to more carbonic acid after all, because of the combination of hydrogen with bicarbonate, the body will try to remove this carbon dioxide, and therefore lungs are doing some work, extra work, and therefore I'm saying the word partially compensated. And why that's important is because suppose I just modify it, pH is lesser, bicarbonate is lesser, so understandable acidosis, bicarbonate is lesser, metabolic acidosis. But if carbon dioxide values are normal, it means the fact that at the moment the lungs have not started their compensation work. Hyperventilation has not started. Small breathing has not started. Then I will write the word uncompensated metabolic acidosis in the patient. So there's a simple aspect that you need to remember. How do you differentiate between uncompensated and partially compensated metabolic acidosis? All you need to do is look at the values of carbon dioxide. If the values of carbon dioxide are lesser, it means that the compensation is occurring. The person is is doing a hyperventilation thanks to the small breathing component. And if that is not happening, it's early part of the disease per se. Now, since my patient was having acute abdomen kind of a presentation, so I decided to even check out the serum amylase values and the lipase values, which can be elevated. Studies have shown that this amylase, which is elevated in these patients, in fact, sometimes striking elevations are present, is mainly of salivary origin. I repeat the fact once again, this is not of pancreatic origin, it is a salivary origin, but the initial presentation of the patient could be looking like that of an acute abdomen, so I decided to get it done. In any diabetic, lipid profile will always be deranged. So hyperlipidemia will be present, and mostly in diabetic patients you will notice it is not LDL, it is rather triglycerides which are grossly deranged. And hypertriglyceridemia, just a matter of fact here, hypertriglyceridemia is an independent risk factor for acute pancreatitis. If in body of somebody triglyceride values are more than 500, normal should be less than 150. If triglycerides are more than 500, they independently are a risk factor for acute pancreatitis. When you read the risk factors for acute pancreatitis after gallstone and alcohol, the medical cause that you will find is hypertriglyceridemia. So diabetic patients anyway, due to hypertriglyceridemia, are anyway at risk for development of acute pancreatitis. I will also be checking the blood counts of these patients, total leukocyte count, because anyway infection is one of the triggers which is occurring in these patients, which is actually contributing to the problems which has finally manifested. We will also check out the anion gap. The formula for anion gap would be that you will take up the positive charges, that is sodium, do not incorporate potassium in the anion gap, and from this you will be subtracting the negative charges, that is chloride and bicarbonate, and the normal anion gap would be usually in the range of about 12 or lesser, but in this particular case the anion gap, because positive charges are increasing, would be increased. So he's going to use a short form here, that is HAGMA. HAGMA would stand for high anion gap metabolic acidosis, is always found in diabetic ketoacidosis. In fact, I would like you to listen to the ABG discussion after you're done with this video. There are 2 videos on ABG discussion which will help you solve a lot of questions, and at least in NEET PG 2021 there were 6 questions which had ABG values given in them. Whether ultimately they asked acidosis, alkalosis is a separate issue, but there were 6 questions that had ABG values given. So I would suggest you to actually listen to the 2 ABG videos after this, so that you will be more comfortable reading the subsequent videos wherever there is going to be any blood gas derangement in a person. We will now be focusing on the treatment of these patients, and well, the treatment will be dependent on whether it is going to be a mild presentation or a moderate or a severe one. So let's have a look at this small classification of how do they classify the subtypes of diabetic ketoacidosis. There are 2 parameters to be taken into consideration. One would be the pH of the blood. Second would be the values of beta hydroxybutyrate. This is one of the predominant ketones which are being produced in these patients. If the pH is something in the range of approximately 7.25 to 7.30, I'm not talking about 7.30 to 7.35, I'm saying already there is a acidosis present, and I'm grading the severity of acidosis. So the moderate patient will be having values between 7 to 7.24, and the severe patient could be having pH values of less than 7. Yes guys, I mean 6.8, 6.9, those outrageously low values can be seen. The values of beta hydroxybutyrate are usually given in millimoles per liter. It could be 3 to 4 millimoles, then 4 to 8 millimoles, and greater than 8 millimoles. Why am I mentioning this classification before you is just to say the fact that if you are gonna identify the disease in the initial part, then electrolyte imbalances will not be seen. Ketostatics will anyway be negative. So there is a possibility that you might think that this person is not having ketoacidosis but is rather having some abdominal emergency. So it's always a good idea that in mild cases also, if you're suspecting that there is a possibility of ketoacidosis in this diabetic who has not been compliant with his insulin, it's always good idea to run a beta hydroxybutyrate values. The plasma beta hydroxybutyrate values are the best way, the easiest way for you to identify this. And over and above this, obviously elevated blood sugar, unconscious status of the patient, all the factors with presence of Kussmaul breathing, which will be mainly present in the severe variety, will add up to confirming your diagnosis. As far as the causes of death are concerned, I have already explained that cerebral edema is common in children, but when it comes to adults, I repeat the fact once again, in a child with diabetic ketoacidosis, I'll just put it at record purposes once again. If he describes a kid and there's an expiry of the child and he says what really went wrong, its fluid shifts across the brain, it's damage to the blood-brain barrier by the cerebral edema component. But if he talks about death in diabetic ketoacidosis with respect to an adult patient, then there are multiple reasons. One could be that he has gone into acute respiratory distress syndrome. Another can be that he is already having diabetic nephropathy contributing to end-stage renal disease, and now the acute kidney injury that is occurring is an added insult. He is already having diabetic nephropathy. Now there's a dehydration, so that can contribute to a pre-renal variety of acute renal injury in the person. He is already a case of ESRD, I said, further insult. Or for that matter of fact, there could be even further complications developing, like a bowel infarction due to dehydration and an increase in the osmolality. And therefore, my first step for management of this case would be, I would like to reduce the magnitude of dehydration by giving IV fluids. He will always ask you, what is the fluid of choice for management of these patients? Do not answer Ringer lactate. Why not Ringer lactate? Because Ringer lactate is rich in potassium, and potassium is already grossly elevated, or maybe grossly elevated in the blood of the patient. Total body potassium is lesser, but in the blood is more. If I give Ringer lactate, the potassium values will spike even further. So I don't want to add, I would say, insult to the injury. The magnitude of dehydration in these patients can be in the range of about 3 to 5 liters. Substantial amount of fluid loss. I have here written the upper limit. In the textbook, you will find a range 3 to 5 liters. This is the usual upper limit, and we try to replenish as much as 1 to 2 liters in the first 2 hours of admission itself. So initially the fluid that I'll be giving to this patient will be fairly substantial. That would be approximately, I would say, 2 liters of fluid over 2 hours. Now the next point which you have to understand is very, very important, because there are two very opposite aspects that I will say. First, I'm saying whenever there is deficiency of insulin, insulin can drive potassium into the cells. You are aware, if insulin is given to somebody, potassium will go inside the cells. But if somebody is having insulin deficiency, then opposite will occur. Insulin and potassium values also go opposite. If insulin is less, potassium will be elevated in the blood. So one more reason I have told you earlier, I was saying pH and potassium have an inverse relation. Now I'm saying insulinopenia itself will contribute to hyperkalemia. So there are two reasons that I've taught you today why potassium can be elevated in the blood of a patient with diabetic ketoacidosis. Reason number one, pH and potassium have an inverse relation. Reason number two, insulin and potassium also have an inverse relation. When you give insulin, potassium goes inside the cells. When insulin is less, potassium will come out of the cells. So you can very well see that there are two reasons operating why potassium can be elevated. So Ringer lactate is something that will definitely not be comfortable in this patient. After 2 hours, I will decrease the rate of fluid administration. We usually give about 300 to 400 ml per hour, and we try to correct the dehydration over the next 8 hours of admission. Now let us assume, and next point is not to be noted, just listen to me. Suppose a doctor is over enthusiastic, or your nurse is not careful and she has over administered IV fluids. I mean, your orders were very precise. You thought, okay, 3 to 5 liter is the correction I will give to the patient depending on the magnitude of dehydration that you anticipated. But a large amount of fluid has been given to diabetic ketoacidosis patients. Then the textbook says that the risk for development of non-cardiogenic pulmonary edema definitely increases in the patient. So it has to be a judicious extra fluid administration, but it should not be over infusion. I repeat again, it should be a judicious extra fluid because there's a dehydration component, but it should not be that over usage of fluids is contributing to death in the patient. Now another point he can put up here, because I told you that there would be electrolyte imbalance and sodium will be less. Because sodium will be less in the body of these patients, therefore hyponatremial manifestations can occur. On the other hand, if the person is having dehydration, two simple aspects. I'll say that again. I said one is that these patients would be having a presence of hyponatremia because there was a fluid shift occurring. Second possibility is the dehydration. If you consider only dehydration component, if you lose water from the body, then sodium values can be elevated also, no? So because these values of sodium potassium can go up also, down also, so a lot of people get frustrated and they leave the topic, but you just need to persist and hang on here. I have taught you the fact that when it comes to potassium, total body can be lesser, but in the blood can be elevated. Now I'm teaching you if sodium values in the body of these patients, in majority of cases, solvent drag, that value that I taught you, 100 point rise, 1.6 milliequivalent decrease, hyponatremia will occur. But initial part of the disease, because of dehydration, sodium values can be increased also. So suppose in the exam, just to make it technical, if he puts up a question in which the value of sodium is deliberately given to be higher, then what fluid will you select for this patient? Simple, you will select N/2. You would be giving half normal saline to this patient, 0.45% normal saline. So please remember this technical fact that if he deliberately gives you sodium values to be in the range of about 130, 128, no issues. You give normal saline to the patient. But if he deliberately mentions sodium values to be higher thanks to the dehydration component, just change the fluid to half normal saline for these patients. Let's move on to the next concept now. You anyway will be handling the blood sugar of these patients. Suppose when you are correcting the dehydration, blood sugar is coming down, because when you give fluids, the sugar dilution effect will again come because of the fluid also. So you anyway have to monitor blood glucose of these patients. Suppose on giving fluids itself, sugar values start decreasing. It was 350 on admission. Now it has become, let me say, 250 milligram. He says that we are gonna, in this particular situation, change the IV fluid to 5% dextrose now. I don't want the sugar values to fall suddenly again, because when sugar spikes or when it falls suddenly, I'm not saying hypoglycemia, all I'm saying is I want to minimize the fluid shifts across the blood-brain barrier. I don't want gross fluctuations in the value of blood sugar of the patient. If sugar value will suddenly spike, if it will suddenly fall, both are going to be detrimental to the integrity of the blood-brain barrier. That's why I said we have to be very, very careful with respect to the choice of IV fluids that we are using in the patient. The learning point at this point of time is don't use ringer lactate, use normal saline. If sodium is more, use N/2. If sugar begins to fall, use 5% dextrose. So that's one of the important points with respect to judicious fluid administration for this patient. And now you will be giving insulin to this patient. Now, as far as insulin is concerned for these patients, we will be using regular insulin because it can be given both intravenously as well as subcutaneously. Initially, the regular insulin that I'll be giving will be a bolus dosage. Most of the time the dosage of regular insulin would be in the amount of approximately 0.1 units per kilogram. You really don't need to remember the amount of insulin to be administered, but why do we need to give this regular insulin is primarily to prime the receptors, and subsequently you can be giving insulin with help of an infusion pump to this patient. So I said two things, initially a bolus dose and then an infusion. The infusion dosage will be 0.1 unit per kg per hour, and the amount of fall of blood sugar with this amount of infusion will be something in the range of about 50 milligram per hour. So in the next couple of hours, you will be able to bring down the sugar values, and I've already sensitized you to the fact that once the sugar values start going down to something in the range of 250 or lesser, you will have to shift over to 5% dextrose in the patient. Now comes a very important aspect. If on admission, I had taught you that potassium values in the body of this patient will be elevated primarily because of the pH issues and the insulinopenia, but suppose the GI losses are very predominant. Suppose this person has been having substantial amount of vomiting, no medical care was given, patient is coming from 200 kilometers away and was vomiting all the way, no oral fluids were given. So because of substantial losses from the body, if on admission, that's an important point to be remembered, if on admission, if potassium is less than 3.5 and you will start insulin drip in the patient, then insulin will start cause potassium to go inside the cells, and this potassium will fall even further. So he says that give a potassium correction in a sense that add KCl to the IV fluid, delay insulin infusion. I repeat my fact once again, you are not to start insulin in any diabetic ketoacidosis patient if on admission potassium values are less than 3.5. Why that is so is because insulin will send potassium inside the cells. The potassium can decrease to 3, then to 2.5, and you run the risk of development of Torsades de Pointes or even a development of diaphragmatic paralysis in the patient. I'll just put that on record. Hypokalemia can even cause a arrhythmia. Torsades de Pointes, because traditionally we read about arrhythmias with hyperkalemia, Another problem can be muscle paralysis, muscle cramps, and a diaphragmatic paralysis, which could ensue. So there will be more problems. In fact, this discussion is all about getting the electrolytes right. So you need to understand all the permutation combinations that I'm explaining to you at the moment. And assuming the fact that potassium is lesser, then I will be adding potassium chloride to the normal saline anyway. The amount of that will vary, and anyway they will not ask you mathematical calculations in the exam. Now, what will you do for management of hypokalemia of this patient? So you will add potassium chloride, and you very well know potassium chloride should never be given in bolus format. So it will obviously be added to whatever IV fluid that is being used at that point of time. It could be normal saline, it could be half normal saline, it could be 5% dextrose. For management of metabolic acidosis, there is no requirement of soda bicarbonate in majority of cases. Only if you are having pH less than 7.0. I repeat this statement. There is no requirement of soda bicarbonate. Why? Because metabolic acidosis is due to ketones. Why are ketones being produced? Insulin deficiency. If you will replenish the insulin deficiency of the patient by giving regular insulin to the patient, then this is definitely going to contribute to resolution of the ketonemia and the ketones in the urine of this person. You, in majority of cases, do not require soda bicarbonate. However, he says if the pH is less than 7.0, you need to increase the pH to a target of approximately 7.1. Why that is so is because, why not 7.2, why not 7.3? Because soda bicarbonate itself is a very concentrated solution. So when you will administer it, it can again contribute to fluid shifts across the brain. And another risk is that if you overcorrect, if you use too much of soda bicarbonate, then overcorrection will contribute to metabolic alkalosis. So it's like you corrected acidosis, now the chap is landing in alkalosis, and metabolic alkalosis contributes to tetany. For this, you will anyway have to refer to the electrolytes discussion, that all types of alkalosis, whether respiratory or metabolic, contributes to tetany. Has been asked in the exam couple of times. Mechanism is given in the electrolytes lecture, but there are two aspects for soda bicarbonate that I've explained to you. I said don't use too much, because too much can contribute to overcorrection, and it is itself a concentrated solution. So fluid shifts across the brain is something that we are already handling at the moment. Then if there is any pneumonia present, if there's any UTI present, then control of that particular infection has to be taken care of. And if it is COVID-19 pneumonia, it's a little difficult to manage because you are anyway giving steroids, and steroids will increase the blood sugar value. So in COVID-19 patients anyway, strict monitoring of blood sugar is to be done, because if you fail to do that, the person can land up in diabetic ketoacidosis. And subsequently, as the patient will pH will start coming back to normal, this person will be shifted to subcutaneous insulin. You can shift him out of the ICU once the patient is able to start resuming his eating, but keep a watch on the potassium values, because if potassium values in this patient keep on fluctuating, it's not a safe decision to send him back to the ward. And anytime if potassium values are between 3 to 3.5, and the person has started taking orally. If I repeat the fact once again, if the values are between 3 to 3.5, patient has not taken orally or is not in a position to take orally, continue giving IV correction. But if he starts taking orally, then obviously oral pot chlor can be given, or banana or other products can be given. In this condition, as the name suggests, the plasma osmolality will be higher. Therefore, the fluid shifts will also be higher. The dehydration magnitude will also be higher. And therefore, the mortality can be as much as 10 times more as compared to the mortality that we encounter in diabetic ketoacidosis. And that's one of the main reasons why we are studying this topic, to prevent this from happening. Let's look at the clinical manifestations here. In majority of cases, the person will not be even aware of the fact that he's suffering from diabetes mellitus. I've written the word occult diabetes mellitus in a middle-aged patient. This particular guy, he is, let me say, retired from any industry, and he's living a very comfortable pensioner's life till one day he has had this trigger which will contribute to a hyperglycemic hyperosmolar state. The trigger would usually be in the form of myocardial infarction. It could be stroke, it could be COVID-19 pneumonia. In fact, this has happened a lot of time that a person suffered from moderate to severe COVID-19 pneumonia. He was admitted in the hospital, subsequently went into encephalopathy because there was a triggering of a hyperosmolar state. Why? Because one, he's anyway receiving steroids, and second, he is not eating anything, so there's definitely some starvation component. But the problem in these patients is that because he's having undiagnosed diabetes mellitus, so there's a relative insulin deficiency. In diabetic ketoacidosis, I was using the term absolute insulin deficiency. Here I'm saying relative because the problem is with the receptors primarily, and there's a sudden increase in the energy requirement of the body. I mean, even if you remove the steroids from the equation, in fact, steroids have been literally abused for the fact that they have caused increased outbreak of diabetes mellitus in India. It's not that the steroids have contributed to more diabetes mellitus. It is simply the diabetes mellitus was very much present in our community. It was hidden, but COVID-19 resulted in those patients being diagnosed as diabetics primarily. So people are obviously non-medical people are saying that, sir, after I got COVID, I became a diabetic, or COVID caused diabetes in me. It was that it was present already in you, but you never bothered to come for a medical checkup till you actually were hospitalized, and then the diagnosis was made. So this occult diabetic, the values of blood sugar will start rising. So unlike when I was describing diabetic ketoacidosis, it's gonna be I would say very fast progression. In hyperosmolar state, it's usually an insidious onset, so it's not gonna be over a matter of hours. It could be days, it could be going up to maybe 7 days, going up to a week as well. And in majority of cases, you will be noticing that the urine output subsequently will start decreasing in these patients, and there could be a development of azotemia. The values of blood urea nitrogen and creatinine will begin to rise. So let's look at a workup of this unconscious diabetic patient, non-case of type 2 or occult unknown case of type 2. And in the workup, the first thing that I will always notice will be that the blood sugar values will be anyway increased, because anybody who's unconscious, unresponsive, you will anyway be doing a metabolic profile, and in metabolic profile, random blood sugar will be done. So initially when the blood sugar value came to be 600-700 mg/cent, I called up the laboratory specifically. I said, sir, are you sure with this kind of outrageously high value? And the laboratory guy said, yes, sir, we double checked on the sample. The sugar values are grossly elevated. Because I said stroke can be a trigger for development of this condition, so it makes sense to do a non-contrast CT head of this patient, a NCCT head. And when I do a CT head, depending upon whether the person has presented early or late, findings may or may not be present. So I've written both the aspects. It could be normal, or we might be even having evidence of either of the two varieties of stroke. I mean, after all, if it's gonna be a ischemic stroke, which is more common, then it's gonna be hypodensity. If it's hemorrhagic stroke, it is hyperdensity. Stroke contributes to increase in the metabolic requirement in the body. So the counter-regulatory hormones will spike. Once the counter-regulatory hormones will increase, the sugar values will definitely be going through the roof. So I thought, okay, we need to run a ABG on this patient, and if I don't get a consent, I can do a venous blood gas sample as well. When I saw the ABG report, the pH of the blood was turning out to be 7.40. The value of partial pressure of carbon dioxide was also turning out to be normal, and the bicarbonate value was also turning out to be normal. So I was wondering to myself when I was reading this report that what is really going on. I mean, I have an unconscious individual, diabetic especially, and I thought he could be having ketoacidosis, but the ABG is perfectly normal. So I also got the urine of this patient checked. Initially the urine output might be more, but subsequently there might be a pre-renal variety of acute kidney injury like manifestations in these patients. Whatever urine sample I have, I will get it evaluated with keto sticks. There is a possibility that the keto sticks might turn out to be normal, but when I'm going to check out the value of plasma beta hydroxybutyrate, the values might be slightly elevated. Now that looks very surprising, because I am teaching you that the person is having non-ketotic hyperosmolar coma. But when you will read the textbook, when you will read the table in Harrison, it will be written ketones plus minus. So minus is understandable. When I say non-ketotic, understandable, hyperglycemia is contributing to problems of this patient. But then why are the ketones increased in this patient is the $1 million question here, or the ₹1,000,000 question from the Indian perspective. Well, this is primarily because of the starvation component. So we might be having ketones. The point is we might be having ketones which are slightly elevated, which can contribute to a misdiagnosis of this patient. So what are you going to do subsequently? You're going to check out the anion gap. I taught you anion gap is always going to be elevated in diabetic ketoacidosis, but in hyperosmolar coma, in majority of cases, it's going to be normal. It can be increased because there can be a component of lactic acidosis. So you will say, sir, you are confusing us. On one hand, you are saying that diagnosis can easily be made. Yes, guys, diagnosis in this case can definitely be made if you are going to check out the plasma osmolality, because when it comes to plasma osmolality in these patients, it will usually be in excess of 330 milliosmoles and even higher. So what I need to do in this patient is put the things in the right perspective. The things in the right perspective highlight that it's values that I'm writing at the moment or marking before you that have to be picked up by you in the exam. Random blood sugar, gross elevations. Plasma osmolality, gross elevations. Bicarbonate values can be normal, or there could be a component where bicarbonate values can be slightly lesser. There are various reasons why it could be lesser. One of them is these patients could be having lactic acidosis developing. That could be one of the triggers, because see, pneumonia can cause sepsis. Sepsis causes lactic acidosis. I repeat again, pneumonia causes sepsis. Sepsis can contribute to development of lactic acidosis. So you might be having some magnitude of acidemia and ketonemia present in these patients. So though I began the discussion by saying the word non-ketotic, that is to put the discussion in perspective of black and white, but there can be shades of gray as well. So you need to have a high index of suspicion to diagnose this patient, and the KFT values in these patients will substantially be deranged. So now let us look at what are we going to do for management of this patient. The treatment of this patient would be first to correct the hyperosmolar state by giving normal saline. The magnitude of normal saline that is required in these patients is pretty substantial, as much as 10 liters, which should be given over a duration of 1 to 2 days. Anyway, non-judicious use of fluids can anyway contribute to a pulmonary edema component developing up. Blood sugar of these patients, if turns out to be less than 250 when you are managing, because once you start giving fluids, they start improving, the hyperglycemic state will improve. In both ketoacidosis as well as in hyperosmolar coma, I have reiterated this statement. If the blood sugar decreases to 250, that's definitely not hypoglycemia, but then sudden fluid shifts are not welcome in this condition. So I would like to change it to 5% dextrose. When it comes to insulin bolus, then in current medical diagnosis and in some books, it is written that insulin bolus is usually not required for priming of the receptors in these patients, because there is no absolute insulin deficiency. It's a relative insulin deficiency. Insulin is very much present. The main treatment for this patient is anyway not insulin, it is IV fluids. I will be giving regular insulin infusion in these patients. The dose will be much lesser. Like in ketoacidosis, I was saying 0.1 unit per kg per hour. Here I'm using only 50% of that dose, and in lots of cases you might even stop it much earlier, because the main treatment of this patient is to bring down the plasma osmolality. If there are some amount of or there is some magnitude of potassium deficiency present in the patient, especially after administration of insulin, which I said was regular one, so insulin will go inside the cells, so you can add potassium chloride to the IV fluids. Similarly, phosphate replacement can also be done in these patients. In fact, phosphate replacement is common to both ketoacidosis as well as hyperosmolar coma. I did not mention it in ketoacidosis part because I just wanted to bring it to point here that you see, whenever cells are going to utilize sugar, they're going to produce ATP. When the cells will produce energy and produce ATP, for production of that you require phosphate. And anyway, in these patients, both ketoacidosis and non-ketotic hyperosmolar coma, they might be having a phosphate depletion in the body. So if you give phosphate or add it to the IV fluids, definitely the patient will be relatively better. And now we will be in a better position to understand the problems that I have just highlighted before you. The main comparison in this table is between diabetic ketoacidosis and hyperglycemic hyperosmolar state, but I will add a new entry here, that is lactic acidosis. You see, why lactic acidosis can occur is because of various reasons. One can be that he is a known case of diabetic nephropathy. He is on metformin, and you know metformin is excreted by the kidney. You have to stop metformin if the eGFR of the patient is less than 30. But the physician who is managing this patient did not bother to check, or the person ever came for a follow-up. The GFR has gone less than 30, metformin is continuously being taken, so lactic acidosis can occur in the patient. And lactic acidosis can not only worsen hyperosmolar coma, it could be present as an independent illness also. How would you be able to pick it up when you are gonna evaluate the pH of this patient? You will notice that pH will definitely be lesser in both diabetic ketoacidosis as well as a lactic acidosis patient. When you will look at the bicarbonate values, you will notice that the values will usually be less than 15 in both of them. So you are wondering to yourself, is it diabetic ketoacidosis? Is it a lactic acidosis? What is going to help you? The urine ketosticks. Urine ketosticks will turn out to be positive only in diabetic ketoacidosis, but will be negative in cases of a lactic acidosis patient. When you will check out the random blood sugar of these patients, the sugar values might be pretty close. Let me say 300 milligram percent here and 350 milligram percent in diabetic ketoacidosis. You see, I'm trying to differentiate the two on the basis of urine ketosticks. And if I'm not sure that, okay, my ketosticks may not be so accurate, so I can definitely go for a plasma beta hydroxybutyrate values. So I'm just going to put up those tests before you here. I can be checking out the serum lactate values for diagnosis of lactic acidosis. In ABG report, lactate values are anyway mentioned, and for obviously diabetic ketoacidosis, I will have to ask the blood bank that they are having the blood sample that I've already sent of this patient, so they can check out the plasma beta hydroxybutyrate value so that you can be sure. But when it comes to a patient of hyperosmolar coma, you are always going to notice that the pH will be normal. The bicarbonate values in these patients will be something in the range of normal, or can be like, let me say 21, 20, but will never be less than 15. So one, I want you to remember, if you get a patient who's having mild level of acidemia versus severe level of acidemia, severe level of acidemia goes more in favor of ketoacidosis, because hyperosmolar coma, there is a possibility for some amount of acidosis to come in, mainly because of the starvation component. Patient is sick, he had stroke, he had MI, he's not eating anything, and maybe he came late also to the hospital, so there could be ketolysis occurring in this patient. And most importantly, you will notice ketosticks will be negative, but blood sugar will be grossly elevated. So just to make the discussion very, I would say, kind of in your face and be able to identify it right away, it is the blood sugar which is gonna help you. And if you can run here plasma osmolality, that's gonna be super increased. I mean, values in range of 330 to 380. I mean, when I write it also, no, I am saying that as compared to blood, I mean, it's 100 units more, which is very, very substantial. Then even partial pressure of carbon dioxide in the ABG report of these patients will be normal, because there is no small breathing, there is no hyperventilation occurring in the patient. And I've already said this fact, but I'm still writing it. Bicarbonate values will be usually in excess of 15 milliequivalents. So the message is, if in a question he gives you ultra high sugar values and he deliberately adds a bit of acidosis, you still have to answer it as hyperglycemic hyperosmolar coma. It's the fluid shifts across the brain which is the primary problem here. And why are you having a ketonemia in these patients? It is written ketones plus minus. That's the explanation that I'm giving to you, because the query of most doctors is, sir, after all ketones are present in ketoacidosis, why here? I said he's sick. It could be MI, stroke, COVID-19 pneumonia, is not eaten anything, oxygen saturation is falling, hospital beds were not available, or he was put in waiting. So maybe outside the ICU he did not get proper care, or maybe he was lying in his car only waiting for a hospital bed to get vacant. So we have seen that ketolysis So we have seen that ketonemia can be present in these patients, but it will obviously be mild. And this table is the main aspect that you need to remember for this particular video, I would say. So if you can just get these values, in fact, if you can just write it down by yourself and get the values logically imprinted in your brain, then I think that you are perfect with respect to this topic. So these are the details I want you to remember. Keep hammering, guys. Keep learning new facts every day, and you grow stronger, and that definitely makes me feel proud of you. Take care. Bye-bye.